Welcome to this ASCO University weekly podcast. My name is Rodrigo Munhoz, and I'm a medical oncologist dedicated to the care of patients with melanoma and sarcoma. Today, I'm going to be talking about recent advances in the adjuvant therapy for patients with high-risk melanoma. Although curable when diagnosed at early stages, subgroups of patients with stage 2 or stage 3 disease do have a significant risk for relapse. As an example, based on the AJCC Staging Manual 8th edition, while patients with stage 3A melanoma have a melanoma-specific survival of above 90% at 5 years, this proportion drops to close to 30% for those with stage 3D disease, highlighting the need for efficient therapies in the adjuvant setting. For many years, despite other controversies involved, the only available systemic agents have been interferon or pegylated interferon. In a recently published meta-analysis based on individual patient data, including 15 randomized trials and more than 7,000 patients, the use of adjuvant interferon resulted in an absolute overall survival improvement of 3% at 5 years. Of note, the benefit from interferon seemed to be limited to patients with ulcerated primary tumors. Nevertheless, this meta-analysis was unable to determine the optimal interferon regimen. Over the past 3 years, however, studies addressing the efficacy of either immunotherapy or combined BRAF and MEK inhibition provided new data to guide treatment decisions for patients who are candidates for adjuvant therapy. The first study to support the use of immune checkpoint blockade was the EORTC 18071. In this phase 3 trial, patients with stage 3A to C disease and at least 1 millimeter of melanoma deposit in the lymph node were randomized to ipilimumab 10 mg per kilogram for 4 cycles, followed by maintenance doses every 3 months for up to 3 years or placebo. The study met its primary endpoint by demonstrating a significant improvement in recurrence-free survival in favor of ipilimumab, with a hazard ratio of 0.76 and an absolute improvement in the proportion of patients without recurrence at 5 years of 11%. Updated results also suggested a significant improvement in overall survival, with a relative reduction in the risk of death of 28%. Toxicities related to the use of ipilimumab, however, have been a major concern. As in the ORTC trial, almost 55% of the patients developed grade 3 or 4 adverse events, and 5 treatment-related deaths were reported. Since 2017, distinct phase 3 studies shed some light on the use of single-agent PD-1 blockade or BRAF and MEK inhibition in the adjuvant setting. In CheckMate 238 study, patients with stage 3B to C or resected stage 4 disease were randomized to nivolumab given every 2 weeks for almost 1 year or ipilimumab 10 mg per kilogram for 4 doses, followed by maintenance doses for the same time period. Although the overall survival results are not yet available, the study demonstrated a significant gain in recurrence-free survival in favor of nivolumab versus an active control arm, with a relative reduction in the risk of relapse of 35%, translating into an absolute difference in the proportion of patients without recurrence of almost 14% at 18 months. Nivolumab also demonstrated a more favorable toxicity profile when compared to ipilimumab. In the Keynote 054 study, patients with stage 3A to C and at least 1 millimeter of melanoma deposit in the lymph node were randomized to either approximately 1 year of pembrolizumab or placebo. Once again, and despite the different study population, the use of the anti-PD-1 agent resulted in an improvement in recurrence-free survival when compared to placebo, with a hazard ratio of 0.57. Finally, results from a phase 3 trial addressing the role of BRAF-MEK inhibition in the adjuvant setting are also available. In the COMBI-AD study, patients with stage 3A to 3C melanoma harboring a BRAF V600E or K mutation were randomized to 1 year of dabrafenib and trametinib or placebo. The use of targeted therapy resulted in a statistically significant improvement in recurrence-free survival, with an absolute gain of almost 20% at 3 years. Also, encouraging overall survival data have been reported, with a hazard ratio for death of 0.57, however not yet reaching statistical significance according to the pre-specified significance boundary. In summary, Emerging data point towards a paradigm shift also in the management of patients with high-risk melanoma treated with curative intent. Based on the results of randomized trials, nivolumab for 1 year may be considered for patients with stage 3B to resected stage 4 melanoma, pembrolizumab for those with stage 3A to C disease, and for those with tumors harboring a BRAF V600E or K mutation, 1 year of dabrafenib and trametinib may also be a reasonable approach. As the field evolves, many aspects remain unclear, including the impact of these strategies in overall survival, the optimal treatment duration, the role of combined immune checkpoint blockade in the adjuvant setting, and the best choice for those with a BRAF mutation. Thank you for listening to this week's episode of the ASCO University Weekly Podcast. For more podcast episodes, visit the Comprehensive e-Learning Center at university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.